Thank you so much, Dimitri. Thank you to Jürgen for their very nice introduction and for setting the stage to my talk. So I'm going to share my screen now and we're going to get started. I hope you can see my screen. Okay, so I'm going to talk to you about what's new in childhood nephrotic syndrome. Going to the current IPNA and KDIGO guidelines and also to what may lay beyond, because we know that the guidelines are always slightly behind the most recent and exciting and innovative discoveries that we make because they need to be verified. To connect with what Jürgen Flügge was mentioning, in the specific case of guidelines for childhood nephrotic syndrome, we were very lucky to have the IPNA guidelines, both for steroid sensitive and for steroid resistant nephrotic syndrome, being created more or less in parallel with the KDIGO chapter on nephrotic syndrome in childhood. And this really allowed us to coordinate and to bring the field forward in a parallel fashion, coordinating our efforts to make sure that everything was uniform, because it's very important to have a common ground and common definitions and common guidance to avoid confusion. So let's get started, and I'll be glad to take questions at the end. I'm a pediatric nephrologist and also a clinical trialist working, and also a basic scientist in reality, working at Bambino Gesù Children's Hospital in Rome. Okay, so the first description of nephrotic syndrome is probably found in this manuscript that describes the 51st disease of children with swelling of their entire body. So nephrotic syndrome has been around for a long time, and physicians have always recognized it in children by recognizing the fact that they had edema, so swelling of their entire body. And it took a while to figure out that that edema was secondary to the massive loss of protein in the urine. So we now know that nephrotic syndrome of children is the most frequent glomerular disease in childhood. Here we have both the incidence depending on the different ethnicities for the whole disease, so childhood nephrotic syndrome. And we see that it is on the left-hand panel most frequent in Asians, Southeast Asians, and people of Arab ancestry. It is relatively less frequent in Europeans. In terms of the separation between steroid resistant and steroid sensitive, once again, there are differences based on the ethnicity of the patients. And more specifically, it tends to be more frequent in patients of Black or Indian race and Southeast Asian or Asian ancestry, and less in Europeans, regarding the more difficult forms of the disease, which are, as we well know, the steroid-resistant forms, which are also the forms that may lead to loss of kidney function, whereas the steroid-sensitive forms are forms that respond to conventional immunosuppression, and as long as a child maintains steroid sensitivity and is therefore responsive to glucocorticoids, kidney function will never be impaired, if not momentarily, during the acute phase of the relapse. So here's some basic concepts that are important to keep in mind. Regarding these diseases, we know that the vast majority, fortunately, are steroid sensitive. And as I was saying, that as long as a patient is steroid sensitive, he will not or she will not progress to end-stage kidney disease. So this is an important basic concept just to get started when you're considering a child that you may be taking into your care. If he or she responds to glucocorticoids, it's a completely different ballpark from if he or she does not. The other thing is that even steroid-sensitive forms, however, may have a rather significant burden of disease because this is a chronic disease that classically has its onset in smaller children between the ages of 3 and 7. And it can last for decades with relapses that can be more or less frequent depending on the patient. After puberty, between 70 and 90% of patients will have a spontaneous and prolonged remission of the disease, so a long-term remission, but a certain percentage, between 10 to 30%, and usually it's the more severe forms that tend to do this, will continue to show relapses even as young adults. And of course, so if we think of a disease that can last decades, even though it doesn't lead to end-stage kidney disease or it doesn't impair kidney function, you realize very well that it does have an important impact on the quality of life, especially due to the fact that we need to use different forms of immunosuppression in order to maintain the child in remission and in order to prevent relapses. And so the therapy that we choose to use needs to take into account a risk-benefit profile that needs to be positive in order to maintain not only as little instances of relapse as possible, but also to minimize the toxicity that can derive from giving prolonged immunosuppression for years and sometimes for decades to our patients. So this is the definition of nephrotic syndrome. This is the definition that you will find when you see both icons, both the IPNA and the KDIGO icon. It's because the two guidelines are identical in this specific instance. And so the definition of nephrotic syndrome is the presence of a proteinuria, which is a very intense proteinuria, so a defined nephrotic range proteinuria. And here you see the numbers that it needs to reach to be defined nephrotic range, together with either, if you can have a blood chemistry, the presence of hypoalbuminemia, which with a serum albumin below 30 grams per liter, or when serum albumin levels are not available, the presence, as we were mentioning right at the beginning, of edema. So the swelling of the body, the edema is visible at the level of the puffy eyes, at the ankles, at the genitals, and we can have pericardial and pleural effusion. So even visiting the patient, you will be able to observe these abnormalities. This combination of instances is defined as nephrotic syndrome. The other important thing that was made clear in the guidelines is that due to the fact that in children it's very difficult to collect urine, we don't expect a 24-hour collection, but rather it is sufficient to have a single sample, optimally the first morning sample, and you can then measure protein, creatinine, and therefore the protein-creatinine ratio in this sample collected in the first morning. And this is more than enough to perform the diagnosis of nephrotic syndrome. Subsequently, you continue to monitor by using a urine dipstick, but it is advisable in the first presentation to have at least once a urinalysis measured in a laboratory, whereas subsequently the urine dipstick is more than enough. Oh, and the correspondence of the nephrotic range is by dipstick to have at least 3+ or 4+. So what is happening in the kidney to determine this intense proteinuria? So we know that the formation of urine starts in the glomeruli, where there's a glomerular filtration barrier, which is in close contact to microcapillaries that contain our blood. And this blood filters through the glomerular filtration barrier into the urinary space, eliminating within the urinary space all the substances that need to be eliminated because they're detrimental, they're not good for you. However, this tightly regulated structure does not physiologically, when it works correctly, allow the passage, for example, of albumin, the main protein of our blood, because these are components such as also immunoglobulins, hormones, etc., that we want to remain within the blood and not to go out into the urinary space. So you see that the glomerular filtration barrier is made of internally blood vessel, which is full of little holes called fenestrae. So it's a highly specialized particular type of endothelium called fenestrated endothelium. The glomerular basement membrane, which is made of different proteins, such as the collagen proteins, nephrin and potosin, and then the proteins that are composed within the pedicels of the podocyte, which is the highly specialized cell that forms these interdigitations, which create like a sieve, so a real filter, allowing the passage only of the substances that we want to pass and not of the others. And this is what is present when everything works perfectly, and you see these beautiful images of a perfectly functional podocyte with pedicels. So in nephrotic syndrome, the whole structure is completely altered. And as you see, these spaces are completely lost. And so the sieve has holes that are much larger than what they would be physiologically. And this allows the passage of red blood cells and of large amounts of protein into the urinary space, leading to proteinuria. So what happens when we have this? We will have a child that presents with puffy eyes. This will be the face of a child with an onset of nephrotic syndrome. So when we see this, something that we have to educate our pediatricians, our basic care, primary care physicians to do is to always, in the office with the child, perform a urinary albustic to check for proteinuria. So, not think automatically only about allergies, but also consider this possibility. This is a very simple but very important first step. So how do we form a diagnosis of steroid-sensitive nephrotic syndrome, and what should we do when we suspect this picture? So in addition to the spot urine that can be done on the first morning void and to a urinalysis, in the blood, measuring serum albumin is useful, measuring blood lipids, measuring a complete blood count where we will see high platelets. We know that we will also see high levels of cholesterol and triglycerides. The kidney function is good to check, even though in most cases it is actually normal. And then there can be microhematuria in the urinalysis in about roughly 25% of patients with a classic idiopathic form of nephrotic syndrome. But if there's macroscopic hematuria, so the urine is visibly red, this should probably make us think of a differential diagnosis with a non-idiopathic form. And we should check things like complement C3, C4, anti-nuclear antibodies, anti-streptococcal antibodies. We know that acute post-infectious glomerulonephritis is very frequent in children, and also, especially if there's an impairment in kidney function, ANCA antibodies. We also should consider, because the vast majority of these children will then receive glucocorticoids, prednisone or prednisolone, to check the titers of their total immunoglobulins and specific, for example, varicella and measles, mumps, and rubella, specific IgG, to recognize non-immunized children, because this is obviously a risk factor, considering that then they're going to have long periods of immunosuppression, and we're going to need to take care of them optimally and try to protect them, trying to immunize them as much as possible between periods of receiving glucocorticoids. So this is quite a complicated graph taken from the IPNA guideline, but the most important concept is, to first of all think if you have a very small child, so a neonatal onset before the age of 3 months, or you have extrarenal features, so a syndromic child, or you have a family history of nephrotic syndrome, you should probably start thinking about performing genetic testing about a genetic form. If you have atypical features, such as macroscopic hematuria, low C3, an AKI, which is not related to the edematous state, so to the hypovolemia, sustained hypertension, or other systemic symptoms such as rash arthritis, then you should probably think about performing a kidney biopsy and trying to rule out other forms of glomerulonephritis. But in the vast majority of cases, you won't, and this is also something that you could consider if the child is older than 12. The classic child that will present you with puffy eyes, and you will perform the urinalysis or the dipstick and find nephrotic range proteinuria, will be younger than that. He or she will be between 1 and 12, but classically between 3 and 7. And in that child, what you do is that you do not perform genetic testing, you do not perform a kidney biopsy, you start standard course of prednisone, of oral glucocorticoids. And the standard course is either 4 weeks plus 4 weeks or 6 weeks plus 6 weeks. The first 4 or 6 weeks are at a so-called full dose, so 60 milligrams per square meter or 2 milligrams per kilogram with a maximum dose of 60 milligrams. And then the following 4 if you did 4 or 6 if you did 6 initially are alternate day prednisone at a dose of 40 milligrams per square meter or 1.5 milligrams per kilogram. The other thing that you need to do is that you need to take care of the edema, of the swelling. So depending on how intense it is, here there's a bit of a picture of what you need to do. So the first thing to do is sodium restriction, because that will help you to get the swelling down. If the edema is very intense, you need to restrict fluids as well. And in some cases, you will need to give albumin with or without diuretics. You need to be careful about giving diuretics without albumin. This is usually a good idea to avoid. You also have a higher risk of thrombosis and of infections due to the fact that you have the hyperdyslipidemia and to the fact that you have hypogammaglobulinemia due to the fact that you're losing gamma globulins with the proteins that you're losing in the urine. So you're going to have to be careful about both thrombotic and infectious complications. So this is just a recap of what we've said. First of all, consider if you can suspect a monogenic disease, consider genetic testing. If you can suspect a secondary cause or an alternative diagnosis, you can consider a kidney biopsy, especially in children above the age of 12, but not limited to this. Otherwise, you start your oral prednisone, and then what do? You recheck your child at 4 weeks, because between 4 to 6 weeks, you're going to have the first super important differential diagnosis between steroid-sensitive forms and steroid-resistant forms. And the vast majority of your children at 4 weeks will be in complete remission and therefore will be defined as steroid sensitive. So now we're briefly going to look at these steroid sensitive forms a little bit more in detail. The other things are the general measures, as we were mentioning, the diet, the fluid restriction if they're very edematous, and the vaccinations whenever possible. So the classification, once the child has achieved his initial remission and is defined as steroid sensitive, is going to be based on the frequency of relapses of the subsequent relapses. And in terms of this, with the most recent guidelines, both IPNA and KDIGO, the definitions have been modified to try to stimulate pediatric nephrologists and people caring for these patients to be more proactive about minimizing the relapses. So the infrequent relapse is now defined as less than 2, so 1 in the first 6 months, and less than 3, so max 2 in any subsequent 12-month period. So conversely, if you have at least 2 in the first 6 months or at least 3 in any subsequent 12-month period, you are defined as frequently relapsing, which is a patient in which you need to think about doing something beyond treating the single episode of relapse to maintain sustained remission. Steroid-dependent remain patients who either relapse during cortisone, prednisone, or within 14 days of its discontinuation. So let's look at the management. So as I was showing you before, we have a long history of disease, a long period during which we have to minimize toxicity. And we can do this in various ways using various different types of immunosuppression. But the goal is to achieve and to bring our patient towards long-term remission. So less than 1/3 of our patients will have infrequent relapses. So they will relapse max once in 6 months or max twice in a year. And in that case, you just treat the single relapses, and I'll show you now with what scheme of glucocorticoids. And you don't need to use anything else, and that's fine. But if you start having from 3 relapses up, and if you have even more, a steroid-dependent form, you're going to have to think about something more. So in some cases, you can simply give low-dose alternate day prednisone. You can try, especially in frequently relapsing patients, at least in the beginning. But the vast majority of these kids will actually need a steroid-sparing immunosuppressive agent. And there can be different types, and we'll look at those as we go along. The other important concept is that the situation is a dynamic situation. So every 3 to 6 or 6 to 12 months, you need to reevaluate the patient. And you always have to think, okay, how has this patient been doing? If the patient is doing well and he's in stable remission, you should consider trying to taper the immunosuppression, especially if that patient has not relapsed for at least a year. Otherwise, you need to instead obtain a so-called control on therapy. So the treatment of the relapses is a standard treatment. Again, the guidelines are very clear about this. You don't need to give prednisone for a long time. You need to give prednisone at 60 milligrams per square meter or 2 milligrams per kilogram, maximum 60, daily until the dipstick is trace or negative for 3 days. Once the dipstick is negative for 3 days, you pass to alternate day, and you give 4 weeks of alternate day oral prednisone or prednisolone for 40 milligrams per square meter or 1.5 milligrams per kilogram. Again, with maximum doses, which should not be above 60 for the main course of high dose, full dose, and not more than 40 for the alternate day. And we also introduced definitions in the guidelines, both IPNA and KDIGO, that were oriented towards trying to introduce the concept that the main goal of treatment is, on the one side, to minimize relapses, but also to allow a certain number, low but acceptable number of relapses, so that we don't overtreat our patients. So if we have ideally no relapses over 12 months, that means that it's sustained remission, and that if we have that, we should scale down whatever treatment that patient is receiving. Obviously, if he or she is not receiving anything, we're happy. And the other definition, however, for more severe patients is controlled on therapy. So if we achieve not a 0 relapse, but an infrequent relapsing, so up to 2 a year, that is still considered acceptable on immunosuppression in the absence of significant drug-related toxicity. So we have to consider that this is a disease that will tend to relapse, as long as it doesn't relapse more than twice in a year, and that the drug-related toxicity is minimal. This is acceptable, and only after 12 months of no relapses do we consider tapering down therapy further. So we all know that glucocorticoids are the most invasive and disruptive and deeply damaging of these therapeutic options. They're wonderful because they work. They work absolutely fantastically, but they have a ton of profoundly disturbing side effects that we need to try to minimize by using them wisely and giving them when they are necessary, but then trying to get rid of them as rapidly as possible. So let's do some practical examples. If we have a little girl who's 9 years old, she had an onset of nephrotic syndrome when she was 5, and then she was fine for until she was 8. But then in the last year, she had 2 relapses in 6 months, followed after 3 months, so within the 12-month period, by a 3rd relapse. So she achieved frequently relapsing status of her steroid-sensitive nephrotic syndrome. At this point, if we think about how she's been treated, we see that her cumulative dose of prednisone, having had the relapses, is actually higher than what it would have been if she had been treated for a first relapse and then left for the following 12 months with a low dose maintenance of oral prednisone on alternate days. So this is an important concept. Alternate day, low dose oral prednisone can be, in frequently relapsing, not severe forms, a potentially very economically viable, but also acceptable therapeutic option to maintain remission. It is better than having repeated relapses if it is sufficient to prevent relapses and to make our patient infrequently relapsing. So again, we have here the different options, but we know that about 60% of our children will either have frequent relapses or be steroid dependent. We can think about alternate day prednisone as a first option, but then we will have to consider also a variety of other immunosuppressive agents to maintain sustained remission. So the selection of the steroid-sparing agent in frequently relapsing and steroid-dependent children with nephrotic syndrome is not easy, and there is not currently sufficient evidence to say that one of the agents is better than another. So it needs to be decided together with the patient or with the parents of the patient, considering also the sort of local situation, so the resources that are available. And the IPNA and the KDIGO guidelines did not feel that they could say more than putting them in alphabetical order: calcineurin inhibitors, so cyclosporin A or tacrolimus, cyclophosphamide, levamisole, mycophenolate, mofetil. And then we will also talk about rituximab. This was also taken up the most recent version of the KDIGO guidelines, which were just published, in which, again, in keeping with the IPNA guidelines, these agents were listed in alphabetical order. So we know that these different agents have positive and negative sides. They also have different cost, and none of them is perfect, but each of them can be chosen depending on the situation. Levamisole can be useful for frequently relapsing nephrotic syndrome patients. It works less well in steroid-dependent. Cyclophosphamide is toxic, but it's also the only agent that can give a long-standing remission, and that has the highest level of evidence to be recommended. Calcineurin inhibitors work really well, but they have a lot of toxicity, so they tend to be considered less optimal, except for steroid-resistant forms that we will talk about in a little bit. Mycophenolate is a very nice drug. It works really well. It can work as well as calcineurin inhibitors if given at the correct dose, but it is more expensive. And then there's the world of the anti-CD20 monoclonal antibodies. They are rather expensive, even though now generic forms are necessary, but they have a series of side effects that we need to be careful about, and they work better in older children. Whereas here we often have to deal with very young children, where the effect on immune competence may be more profound. So to really define the best treatment strategy, we would really need for each patient to be able to understand the underlying physiopathology. But in reality, we know that this is an immune-mediated disease, but we don't really know why. We don't really know what the T cells and the B cells are doing to alter the structure of the podocyte. So what is the etiology of steroid-sensitive immune-mediated nephrotic syndrome? We don't know how we get to this, what happens in our immune system to determine this. So different theories have been brought forth. We know that in genetic forms, it's a different genetic alterations of different proteins components like nephrin and podosin, integral components of the podocyte, but also other types of proteins that are important. But with the immune system, things are a little bit less clear. So up here, we have less clarity. So for many, many decades, starting from an important landmark paper that was published in The Lancet in 1974 by Chaloub, childhood nephrotic syndrome was considered a T-cell disorder. However, many of the evidences of a T-cell involvement are exactly applicable also for B-cell involvement. The sensitivity to steroids, to cyclophosphamide, the association with certain types of cancer, the spontaneous remission after measles, etc., etc. But the most compelling evidence for a B-cell involvement is the efficacy of B-cell depletion with anti-CD20 monoclonal antibodies, primarily with rituximab. So this was started and first observed in 2004 with this child. This was a child who had had nephrotic syndrome for quite a few years. And you see here in the lowest part, the relapses. He had a ton of relapses, despite receiving prednisone, cyclosporin, cyclophosphamide, tacrolimus, all the agents that we've mentioned. Then he developed another disease, ITP. And for this ITP, he was treated with rituximab, a single dose. After a single dose of rituximab, his nephrologist was able to discontinue everything, and the child never relapsed again. So from this initial description, the EGMA randomized controlled trial versus placebo, demonstrating the efficacy of rituximab in patients with childhood onset, complicated, frequently relapsing, and steroid-dependent nephrotic syndrome, 10 years passed. But this really proved that rituximab was a very attractive option for these patients. And this is data from the first 40 patients that we treated in Rome. 8 of these 40 patients, most of them after having received a single dose, never relapsed. So even rituximab proved itself in a small percentage, about 20% of patients, and in other groups it's less than this, to be potentially disease modifying. So to really change the disease completely. So in our laboratory, Manuela Colucci, together with all of us, has been trying to study the B-cell compartment of children with nephrotic syndrome for many years to understand what underlying abnormalities these children have. So we know that the B-cells are created in the bone marrow. They go into the periphery as transitional B-cells, mature B-cells, and then they are activated. They do class-switched recombination, and they become first IgM memory B cells, and then once they go through class switch recombination and isotype switching, become either IgA, IgG, or IgE, switched memory B cells and short-lived plasma cells, and then they go back into the bone marrow as long-lived plasma cells, creating the immunological memory, the B cell memory that our children need to have to be protected against infections. So when you look at all the different subpopulations of B cells in children with nephrotic syndrome at onset, in relapse, and in remission, compared to age-matched healthy donors, most striking abnormality that children with nephrotic syndrome have is that both at onset and in relapse, but not in remission, they have a higher number of memory B cells. And memory B cell levels, the higher memory B cells, are also predictive of particularly severe steroid-dependent forms of nephrotic syndrome since onset. So memory B cells really seem to be, high levels of them really seem to be a trademark of a difficult form of immune-mediated nephrotic syndrome. And this was demonstrated by many other groups in other parts of the world, and also by single-cell RNA-seq more recently in this important paper published in Nature Communications a year and a half ago. So what do B cells do? B cells make antibodies. So people have been looking for antibodies in minimal change disease of adults or in childhood nephrotic syndrome models for a long time. And the anti-CD40 antibodies had been proven to be pathogenic in a mouse model. Anti-UCHL1 had been proven both in patients and in a mouse model by Georges Deschamps' group in France. And more recently, in 2022, Astrid Vine's group from Harvard published this important paper in which, both in adults with minimal change disease, in the kidney biopsies and also in the circulation, but also in a few children, they found antibodies directed against nephrin, so the key component of the glomerular filtration barrier of the pedocells of the podocyte. So this was followed by another important publication in which we also contributed last year, in which this was looked at in more detail using a different assay, a hybrid IP-ELISA assay, so looking at the circulation of patients. And once again, not in other forms of protein spilling diseases, so not in membranous, not in controls, but only in adults with minimal change disease or with primary FSGS, and particularly in children, anti-nephrin antibodies were identified, and it was also shown that in a mouse model, these antibodies taken from patients were able to create the disruption of the glomerular filtration barrier. Here you see the percentages being really very high, 35 out of 39 in children, in particular if they had not received any immunosuppression and they were active, so nephrotic, really indicating that there seemed to be a correlation between the presence of these antibodies and the activity of the disease. Now, this is something that needs to be confirmed. The assay is very tricky to perform, so I think there's still a lot of work to be done, but this really points in the direction of confirming a crucial role of B cells in these diseases. And if you look at this, the correlation between the anti-nephrin antibodies and the proteinuria, so the activity of the disease, is really very convincing. In 14 children from our center, in which we had samples both at onset and in remission, only one that was still positive here while he was in remission relapsed 4 days later, really indicating that there is a functional correlation. So when we think about the different B cell compartments and when we think about the drugs that we can give that have a role on modulating B cells, we see that the only drugs that actually work on memory B cells specifically are the anti-CD20 monoclonal antibodies, rituximab, ofatumumab, or obinutuzumab. So when should we use rituximab in children with steroid-sensitive forms of nephrotic syndrome? So in the guideline, it is recommended to not use them as a first-line steroid-sparing agent, but to only use them as a second line after a first line has not worked. It is to be given at this standard dose, and it seems to work better in older kids. And I'll show you a little bit more about this in a second. So you should check CD19 cell count. You should check immunoglobulin levels at baseline. You should pre-medicate. And following the rituximab infusion, you should taper off the oral prednisone or other steroid-sparing agents quickly, except in selected cases that I will discuss shortly. This important paper by Eugene Chan showed also that the repeated infusions can continue to be effective, and therefore it can be given more than once, and it should be when necessary. Even though we don't know exactly when to decide to give rituximab again, and this is still an open question, and that in children with particularly complicated and severe forms of frequently relapsing or steroid-dependent nephrotic syndrome, giving MMF post-rituximab, as was demonstrated in this randomized controlled trial again by the Japanese group, is beneficial. The reconstitution of B cells is slower, and as long as we give MMF post-rituximab, the number of relapses is significantly lower. So let's look at some challenges and future perspectives, just a couple of concepts. So the memory B cells are not only predictive of patients who will have severe steroid-dependent forms of nephrotic syndrome, but they also, post-rituximab, predict relapse. Not total B cells, but memory B cells predict relapse. Another important concept is that when we're looking at what predict relapse at baseline before giving a dose of rituximab, we see that age is very important. And the cutoff is 9.8, so we can say 10 years. And older children tend to relapse much less compared to younger children. And so this is really something to keep in mind when we're caring for our patients. The age at the time in which we use the anti-CD20 infusion is associated with the risk of relapse. The younger the child, the worse, the higher the chance of relapse. And this is in close correlation with the fact that younger kids have higher memory B cells levels at baseline, and they also reconstitute their memory B cells much faster. Therefore, they are more prone to relapsing fast. Another concept is what we're doing to the immunoglobulin levels. Since we're giving the precursors of plasma cells, that are the cells that produce immunoglobulins, during the formation of the immune competence, which happens in a child in the first 10 years of life. So what is the situation in a child with nephrotic syndrome at onset before receiving any form of immunosuppression, including glucocorticoids? So we know that when you have active nephrotic syndrome, you're losing immunoglobulins in the urine. Therefore, the levels of both total and specific IgG, for example, anti-tetanus or anti-hepatitis B, is going to be really low because you're losing them in the urine. However, if you look at the cells, the memory B cells that either have total IgG or anti-tetanus IgG or anti-hepatitis B IgG, completely normal compared to a healthy age-matched control. So the immune competence of a child with nephrotic syndrome before receiving immunosuppression is normal. What we're doing, however, when we're giving rituximab is that we are depleting memory B cells even for more than 2 years. Here we have some patients that have a follow-up of 9 years and that still have very low levels of memory B cells. Their total B cells are going to be normal, but their memory B cells are going to be low, and that's why they don't relapse. But it also means that they may have an impaired immune competence. And in parallel, we will see low immunoglobulin levels, not in all patients, but in some. And those patients can have very prolonged and protracted hypogammaglobulinemia. Some of them, very few, will also need substitutive IgIV. So we have to recognize and check total immunoglobulin levels, even in patients with nephrotic syndrome who received even a single dose of rituximab quite a few years before. And what is the main predictor of the hypogammaglobulinemia? Age. The younger children are much more likely to develop hypogammaglobulinemia post-rituximab. So in younger children, you have a higher risk of severe infection, a higher risk of sustained hypogammaglobulinemia, a faster B cell recovery with a higher risk of relapse, and a reduced immune competence in terms of vaccines. Another important concept is that very often after giving rituximab, we do see that the total immunoglobulins are restored. However, we see that the specific, for example, anti-tetanus immunoglobulins are not restored. So you lose your vaccine competence. In these patients, however, if you revaccinate, you will see that perhaps the titers will remain low. If you look at the actual memory B cells that are specific, these can be restored. So it's very important to remember to boost our patients for the most important vaccines, for example, hepatitis B or tetanus. So when you're using rituximab, the optimal response will be obtained in older children, particularly above the age of 9 or 10. Using mycophenolate mofetil after rituximab in severe forms of steroid-dependent nephrotic syndrome will make its effect stronger. It's important to monitor IgG levels both at baseline and periodically after rituximab. And post-rituximab, once total B cells are reconstituted, don't look at memory, total B cells, you need to assess vaccination status and administer booster vaccination. Okay, now let's quickly conclude by talking about steroid-resistant nephrotic syndrome. So steroid-resistant nephrotic syndrome is that small percentage, fortunately, of very difficult patients who will not respond to glucocorticoids. So historically, we said that the response was defined as no response after 8 weeks of steroids. This is an old slide. In reality, though, if you look at the data, look at here we compare children and adults. So this scale is days, and the scale for adults is weeks. So adults really take a long time to respond to glucocorticoids, but children, the vast majority, 98% more or less, will respond in the first 28 days. So in the first 4 weeks. So when the IPA definitions and then the KDIGO definitions looked at this, they recommended to confirm remission at 4 weeks. And the vast majority of patients will be either steroid sensitive or steroid resistant at 4 weeks. However, if a patient has only partial remission at 4 weeks, then you wait between 4 and 6 weeks and you reassess. And you will have a percentage of patients who will go from partial to complete remission, and these will be called still steroid sensitive nephrotic syndrome, but late responders. All the others, if they have not responded by 6 weeks, will be called steroid resistant nephrotic syndrome. Why is this really important? It's really important because, as we were mentioning before, while steroid sensitive forms may be important in terms of long-term effects on toxicity and everything, but they will never impair kidney function, steroid resistant nephrotic syndrome can lead to end-stage kidney disease and renal transplant. Within steroid resistant, fortunately though, a vast majority will respond to a second line with a calcineurin inhibitor, and those are called multi-drug sensitive. Those will go on to have multiple relapses like the steroid sensitive forms. There will then be some forms who never respond to anything. Those are the genetic forms, which will never recur post-transplant. And then in the middle, all of the immune-mediated forms, even the forms who initially respond and then lose their capability to respond to immunosuppression, those are very difficult and severe forms because not only will they lead to end-stage kidney disease, but they also have a high risk of recurrence after transplantation. So steroid-resistant nephrotic syndrome in children is divided between immune-mediated forms and monogenic familial forms. So how can we recognize the monogenic forms? Very young children, typically congenital, but also within the first year of age, the presence of extrarenal features, and the presence of family history. And more specifically, here you see all the different extrarenal features that can really be very heterogeneous. We can have mental retardation, microcephaly, seizures, ataxia, hearing loss, ocular abnormalities such as microchoria or cataract, thrombocytopenia, ambiguous genitalia, peripheral neuropathy, nail and patella of the knee alterations, or immune deficiencies such as Schimke immunoosseous dysplasia, also with low stature. So in these cases, we should perform genetic screening. And the genetic screening results will change depending on the age of the child. In the first 3 months, the vast majority will be nephrin mutations, followed by Potosin and WT1. From 4 to 12 months, we will have about one-third, one-third, one-third WT1, Potosin, nephrin. And subsequently, Potosin will be the most frequently found mutation. And the gray, which is the other, will start to appear specifically in young adults. And the other are now known to be very often called for A5 mutations. So same types of mutations that you see in Alport syndrome that can instead give focal segmental glomerulosclerosis. So an NGS panel will really capture the vast majority of these mutations. And the other important concept is the kidney biopsy. So biopsy should not be performed routinely in these children. However, if we have older children, atypical features, those are children in which we need to think about performing a kidney biopsy. So the kidney biopsy, you see the cutoff is really 12 because until 12, the vast majority of the kids will have minimal change disease or FSGS. It's after 12 that you start having membranous and then other forms such as lupus, IgA, and C3 glomerulopathy, whatever. So at this point, it can be useful. The biopsy, when performed, will most frequently give either a minimal change disease or FSGS, and now we know that this can be a spectrum depending on the timing of the biopsy, or a diffuse mesangial glomerulosclerosis, also going towards FSGS. And then in about 20% of cases, you can have other diseases such as IgA, membranous, Alport, et cetera. So how do we manage these patients? So we know that it depends on whether they're monogenic or immune-mediated. And it's really important to distinguish because the genetic forms invariably will lead over a variable number of years transplant. The post-transplant relapse risk will be 0%, whereas the non-genetic forms will also, if not treated and not responsive to treatment, lead to transplant. About half of the cases, there will be a relapse. So this, even on the transplanted kidney. So this means that the disease continues to recur with huge consequences for the patient. The other thing is that on the native kidney, even achieving partial remission, but most importantly, complete remission, makes a humongous amount of difference in terms of years of kidney survival that we give to our patients. And this is particularly compelling for children. So what do we need to do if a patient is steroid resistant? While we are investigating by kidney biopsy and genetic screening what the causes may be, we start a CNI, a calcineurin inhibitor, and at the doses recommended in the guideline. And we do this because the vast majority of immune-mediated forms will respond. So you see here, if we think that it's immune-mediated, we do this together with an ACE or an ARB. If we really are sure that it's a monogenic form, then we don't even start and we only use an ACE or an ARB. Why is it so important to give CNI? Because well over 50%, in some cases, case histories or descriptions up to 90%, will respond to a calcineurin inhibitor, even though it can take many, many months. So in the guidelines, what it is said that we start the CNI, either cyclosporin or tacrolimus, and then we reassess. So in patients who go into complete remission, we keep the CNI for 12 to 24 months, and then we try to consider conversion to mycophenolate mofetil to maintain remission. In the patients who have partial remission, it's really quite difficult to decide. And in the patients who have no remission, we need to start thinking about second-line approaches. These are really patients that need a multidisciplinary, highly specialized approach. And in these patients, you either enroll in a clinical trial or you consider rituximab. And Professor Eugene Chen will be talking about rituximab and steroid-resistant nephrotic syndrome in a few minutes. So with this, I conclude, and this is the main bibliography. The new KDIGO guidelines just published this year, the IPNA guidelines, both the 2023 and the 2021, and a couple of reviews, in particular the last one by Boyer, if you have a child with congenital nephrotic syndrome, can be useful. Thank you very much, and I'll be glad to take your questions.